Είμεθα στο Δημαρχείο του Enfield, στο Silver Street, όπου σήμερα ή μάλλον απόψε λαμβάνει η χώρα ένα σεμινάριο γύρω από τον προστάτη και τον καρκίνο του προστάτη, όπου θα έχουμε τον Professor Mike Embeton να δώσει την ομιλία και τον Dr Abedi, ένας γιατρός που εργάζεται εδώ στην περιοχή του Δημαρχείου του Enfield. Το σεμινάριο αυτό οργανώνεται από το σύνδεσμο Λευκαριτών σε συνεργασία με το NHS Enfield, Healthe Enfield και φυσικά και με την επιχορήγηση του Δημαρχείου του Enfield. Σε μια βροχερή νύχτα η παρουσία πολλών, όχι μόνο στην πατριωτό μας, αλλά και από Άγγλους και άλλους ξένους, έχει γεμίσει η αίθουσα του Conference Room στο Δημαρχείο του Enfield, όπου θα παρακολουθήσουν αυτόν το ωραίο σεμινάριο, το οποίο, όπως με έχουν πληροφορήσει, είναι η πρώτη φορά, είναι νέο έδαφος αυτό που μπαίνει ο σύνδεσμος Λευκαριτών, και όχι μόνο, διότι όπως μου έχει πει η Karen Keane, η συντονίστρια του press screening, είναι η πρώτη φορά που τέτοιου είδους σεμινάρια λαμβάνουν μέρος στο Δημαρχείο του Enfield, και θα ζητήσουμε τη γνώμη όλων των παρευρισκομένων τι άλλα σεμινάρια, τι άλλα θέματα θέλουν να παρακολουθήσουν οι κάτοικοι του Enfield, και όχι μόνο, διότι αυτά τα σεμινάρια είναι ανοιχτά και στο Δημαρχείο του Enfield, σε γειτονικά δημαρχία, και έχω διαφημιστεί και από το Hellenic και από άλλα μέσα μαζικής ενημέρωσης για να λάβουν όλοι, διότι το θέμα υγείας δεν είναι μόνο θέμα υγείας για όλους τους κατοίκους του Enfield, αλλά για όλους τους κατοίκους της χώρας αυτής, για να βελτιωθεί η ποιότητα ζωής. Η πρόληψη είναι, όπως λέμε, η πρόληψη είναι καλύτερη από τη θεραπεία, και έτσι όσο πιο γρήγορα, όπως είπαν και άλλοι, όπως θα ακούσουμε, είναι ότι το chance να ζήσει κάποιος περισσότερα χρόνια είναι όταν το προλάβει το κακό πριν προχωρήσει. Ο σύνδεσμος θα συνεχίσει τα σεμινάρια αυτά, τα οποία είναι καλής ποιότητας, και δεν λέω μόνο για το φαγητό, αλλά και για το περιεχόμενο των σεμιναρίων, με διαλεκτούς ανθρώπους, γνώστες σε αυτά τα θέματα, και θα συνεχίσουμε το σεμινάριο αυτά μέχρι και 31 του Οκτώβρη, που λαμβάνει μέρος το καρκίνος στο Latimer Road, Churchfield, ο καρκίνος του μαστού, το οποίο, όπως έχουμε ακούσει και θα το ξαναπώ, 400 ανθρώποι λαμβάνουν αυτή την ασθένεια κάθε χρόνο στην Αγγλία. Εύχομαι να έχουμε περισσότερους συμπατριώτες μας στα επόμενα σεμινάρια, και όπως ξέρουμε ο Οκτώβρης είναι ο μήνας που είναι αφιερωμένος στον καρκίνο του μαστού και σε άλλα θέματα καρκίνου. Έτσι ο σύνδεσμος Λευκαριτών ανταποκρίθηκε επάξια για να γνωρίσει σε όλους τα συμπτώματα και πώς να θεραπευτούν.
I would like to thank you all for coming on a rainy, full of traffic evening, and we have to start although people still arrive, and to thank all those who are involved in this project. On behalf of the Lefkar Association, a charity association which was formed 26 years ago, I would like to wish you a good evening. And to introduce and to welcome the First Lady, Councillor Kate Anolue, the Mayor of Enfield. Thank you for coming at the short notice, Madam Mayor. And also Dr Abedi, thank you for covering the short notice for Dr Gokman, who is not feeling very well, unfortunately. And Dr Mike Embeton, which is a consultant, UCH, for cancer, and a former prostate cancer patient who fought it. He's a fighter. He has to be, he's a former Enfield employee. I've known him when I first started as a counsellor. And indeed, Karen Keane, which is the outreach worker on for press screening and promoting awareness across the borough. Enfield NHS, the London Councils for funding this event, and Healthe Enfield. And indeed to welcome tonight Councillor Ingrid, any other councillors here? Oh, Eric Jukes, thank you Eric. And by no means this is Councillor Christine Hamilton, who happens to be the cabinet member for communities and has helped us and supported us throughout. Christine, I would like you to come here, please. If you be kind enough. I know you don't like the. There is a chair. Thank you for coming anyway.
Thank you so much.
Can I say good evening to everyone here?
Good evening to you.
Oh, that's fantastic. Thank you very much. You can show so much energy that you've got at this time of the day. That's really wonderful. I think it's a great pleasure to be called, to come and obviously help to start this seminar. Like we all know, health is wealth. If you're well, I tell you, you are the richest person. Forget about that person who's got the money, but the person who is well is very rich. And it's so nice, and I'm so impressed that with the weather as it is, you still come out to come and listen to our professionals. They've given up their time to come and talk to you. And the amount of people that are here, not much, but remember that one person can spread the word to hundreds of people. So what you hear here, please spread out the news out there so that those who are not here can also get the message. And I can probably say, I don't see a lot of Afro-Caribbeans here, and yet we seem to be at the high risk. So maybe the women, our women have to talk to our men to come out, because they should be here to listen to the experts. So maybe next time we have used another technique to get them out, because I know that majority people from my own side don't like to talk about illness, and that's why people die silently. So I think that's one thing that we really have to take aboard, to go and spread the news to them and get the women to get them out, because it's so important that we all listen and be able to help one another. So I hope you have a good evening. I'm sorry that I can't be here for the rest of the event, of the seminar, because I've got another mayoral engagement in the mayor's parlor there. So I'm going to miss this, but I am with you all. And welcome again to Enfield Council here, and I hope you have a very fruitful and knowledgeable evening. Thank you very much.
Good evening and welcome. As mentioned, I'm Dr Abedi. I'm a local GP, a practice not far from here in Ponders End. Now, I'm going to keep things simple, so I'm going to give you a very brief talk about prostate cancer from the perspective of a GP, and I hope it's informative and patient-friendly, because there's a message that we want to impart here this evening. So why are we here? Well, prostate cancer is the most common cancer in men. A quarter of new cases of cancer diagnosed in the UK are those of prostate cancer in males. And in 2009, nearly 41,000 people were diagnosed with prostate cancer, and that's 112 every day. Now, what I'm trying to say is that it's really common, but it's amenable to treatment. We can treat this if we get it early. So recognising the symptoms, the early symptoms of prostate cancer is very, very important. So risk factors, as our Honourable Lady Mayor mentioned, one of the risk factors is ethnicity. Being Black African or Afro-Caribbean gives you a higher risk of developing prostate cancer. There is a link to family history, so a first-degree relative, father or brother, will have an increased chance of developing prostate cancer. And age, there is a risk, an increased risk beyond the age of 50. This slide bears out what I've just mentioned about age. As you see, the graph goes up after the age of 50, so the average number of cases detected increases after the age of 50, and the number of deaths also increases after the age of 50. And one of the reasons is because we detect prostate cancer quite late in elderly patients. So again, there's the importance of detecting this cancer early. So what are the symptoms? So having to go to the loo, having to rush to the loo, especially at night time. When you get there, having a symptom called hesitancy, so it's difficult to pass urine. The stream of urine is weak. The bladder emptying, so when you walk away from the loo, you feel like going back again within minutes, and you may experience some dribbling as well. There are also symptoms of pain or blood in the urine, so you might see some blood there. So that's a very important slide, because those are the symptoms, and if you have any of those, does anybody need to know? Well, you need to see a GP immediately. So any of those symptoms, you need to go to your GP. When you get to your GP, what to expect? So your GP will take a full history. He'll examine you fully, and especially examine your prostate. And on the basis of examination, he may send you for a blood test. And we'll discuss the blood test in a minute. It's called the prostate-specific antigen, the PSA blood test. Now, depending on the finding of on examination and on tests, your GP may start you on some medication, or he may refer you to a specialist. So, coming to the test, how do we screen for prostate cancer? Now, we don't have a formal screening test, unfortunately. The gold standard is a biopsy, and that's an invasive test, and it's fraught with complications. And when we pick screening tests, we tend to pick those that in which the benefits outweigh the risks. So, so having a biopsy on every patient isn't probably practical. And the PSA blood test, we'll come to that now. Prostate-specific antigen is not a good screening test. The reason is that there are many conditions that can cause a rise in PSA other than prostate cancer. So you may get a false positive test. And more importantly, you may get a false negative test. That would mean a test would be negative in the presence of cancer. And for obvious reasons, that's dangerous. So PSA is not a good screening test for prostate cancer. So that's just an overview of prostate cancer, and there are sort of many sites that you can go on. I'm sure, having spoken to a lot of people here, many of you are patients, and I'm sure that some of that information is, you knew exactly what I was talking about there. But there are sites that you can go on. There are support sites if you have the illness, and we can provide you with those after the meeting. What I wanted to talk about also today was some of the good work that's been done in Enfield, and we want to make sure that we get even better at this, and that's some of the screening programs that are going on within the borough. We are currently screening women aged between 50 and 70 for breast cancer, and we're doing that in the community at Forest Primary Care Centre in Edmonton on the Hertford Road, and it's going very well. We screened more than 70% of the eligible population of women last year, and that is the largest in London, I'm informed, which is excellent. I think that's really good. So, you know, we're hitting that, and I'm really proud of that. I'm an Enfield resident, and, you know, I'm rightly proud of that. Excellent. Now, bowel screening. I'm not so happy about this as a GP. How many of you have had a stool sample kit? Show of hands. Okay, hands down, hands down. So how many have returned the test?
Oh wow.
Well, that's not bad.
Not a representative.
Well, that's not representative, because if I had a group of my patients here, you would have had, for the second question, hardly anyone would have raised their hands, and it's a big bugbear of mine. It's an easy test to do. Bowel cancer is easily detected by this test, so please return the kit. I don't have to tell you that, but I'm informed we're going to be on YouTube, so hopefully someone will watch this and listen to what I've said. So we're just an overview. We're screening everyone between 60 and 74 years of age every 2 years, and we're pretty high in London with 56% screened last year, but I want that much higher. We can get that better. We need to get that better. Next one. Cervical screening. So women up to the age of 65 have a cervical screen. From 25 to 65 are screened for cervical cancer, and that's a simple test done at your GP practice. This test picks up early changes of cancer, early changes that might develop into cancer, so it's very important. Currently in Enfield, we're at 78%, and that needs to be better. That needs to be much better than 78%. I would go on, aim for at least 90. We're going towards 90, so cervical screening is extremely important. Right, so that was just an overview of prostate cancer from a general practice perspective. There are some contacts, as I've mentioned, which are available at the end of the meeting or after the meeting. Our next speaker is Mr. Tony Harrison, who is a volunteer for Prostate Cancer UK and a past patient with prostate cancer, and probably the most important person here, and probably I think we'll all value what he has to say. So thank you.
So everyone that is a volunteer has been affected by prostate cancer. Either they've been diagnosed with it and are living with it, or have had treatment and hopefully are free of it, or their relatives, could be a wife, could be a daughter, who have seen the effects of prostate cancer. The other role that we do is that we go out and we do awareness talks, and I'm going to run through very quickly what the awareness is. Some of it will repeat what you've already heard. Another role that we have is peer support. People that ring into Prostate Cancer UK perhaps have just been diagnosed, are deciding what treatment they want to have, and they have the opportunity to talk to someone who has been through the treatment program that they're thinking about, and to ask questions. The usual questions are, what are the after effects? How's it going to affect me in the future? And we can talk to them about that and give them the benefit of our experience. We don't give them advice of what they should do. We purely tell them how it affected us. Right, moving on, you'll see the first one is what the Prostate Cancer Charity do. They've renamed themselves, they're Prostate Cancer UK now, but they haven't given me any new slides. They fight prostate cancer through research, support, information and campaigning. So that's the first slide. You've heard it's the most common cancer in men. You had a higher figure, 41,000 now diagnosed. One man dies every hour of prostate cancer, which is quite a, when you think about it, it's quite a figure.
Is that in the UK or the world or what?
No, in the UK.
In the UK.
The prostate gland is out of sight and out of mind. 70% of adults in the UK do not know what the prostate does. I'm sure you all know, because that's why you're here this evening. But I have been and done talks where I had gentlemen that thought ladies had prostate. So that's the sort of the amount of ignorance that is about the prostate. Where is it? For anyone that doesn't know, it's just below the bladder and the urethra passes through it. It's part of the male reproductive system. Sex gland makes one of the fluids in semen. Now, what can go wrong? Not only cancer, benign prostatic hyperplasia. I think I've got it. And that's a non-cancerous enlargement of the prostate. Prostatitis, which is inflammation or infection of the prostate, and prostate cancer. Prostate cancer may cause similar symptoms to non-cancerous prostate problems. You've heard about those things: weak urine or reduced urine flow, need to urinate more often, especially at night, feeling the bladder is not emptied properly, difficulty starting to pass the urine, dribbling urine, and needing to rush to the toilet. You know, how many men getting up 2-3 times a night and running to the loo? Less common symptoms are new pain in the lower back, hips or pelvis, problems getting or keeping an erection, and blood in the urine or semen. Some men with prostate cancer may have no symptoms at all. Personally, I had no symptoms. It was purely that I listened to a talk, similar to your hearing this evening, and we were told at that time, and this is going back 11, 12 years, that if you were over 55, you ought to have a PSA test. I hurt my knee, and I went to the doctors about 3 months after the talk, and he said, oh, I think I'll do a blood test. So I said, while you're doing it, can you do me a PSA? He said, yes, I'll do your PSA. Came back at 11. Should be 4 or lower. So I went off to see a consultant, and I won't mention for embarrassment for any which hospital, but the first thing the consultant said to me, do you really want to know if you've got prostate cancer? I said, yeah. He said, well, he said, you know, it would take 10, 15 years to kill you. I said, I'm only 60. So he said, oh yes, well, okay. He said, I'd never had my PSA done though. Anyway, fortunately he sent me to another consultant who had an entirely different attitude, which I'm very pleased to say, because they didn't do the operation in the hospital where he was the consultant. Right, moving on. First thing to do is a
Can I ask, how long have you had it?
Pardon?
How long have you had prostate cancer?
I hope I haven't got it. But I was diagnosed 11 years ago,
Right.
or 12 years ago this month, and I had an operation about 10 months later, and I've been free of prostate cancer since.
Was that to remove it?
I had it removed, yes.
Mm-hmm.
But there's other treatments, and I'll perhaps touch on those quickly if I'm not crossing with Professor Embeton's talk. First thing, urine test, check for infection. Second, PSA test. And then the digital rectal examination, which a GP does. I'm sure you know what that is, so I won't go into that. But that shows you how he does it. Right. The next thing if they feel that there is a problem, is the biopsy. That is taken virtually in the same way as the digital examination, and as you've been told, there are risks to that because of where they're taking it from and so on. So we'll move on. 85% of prostate cancer is diagnosed in men over 60. African and Caribbean men are 3 times more likely to develop prostate cancer than white men. So you heard what the Lady Mayor said about it, and now you know the reason why. Family. You're 2.5 times more likely to develop prostate cancer if your father or brother has had it. My father hadn't had it, but I got it. Diet. I always feel a little bit about this one, that you'll get this advice whatever's wrong with you. If you have a diet rich in fat, dairy products and red meat, this may increase your risk of developing prostate cancer. I'm sure the doctor would tell you there's a lot of other things it would most probably increase your risk of. What can you do about it? Maintain a normal weight for your height, avoid fatty foods and try to decrease your fat intake, eat red meat and processed meat in moderation. Eat more fruit and vegetables, vegetables in the cabbage family, light beans, green tea, oily fish, soy, whole grains. Broccoli is very good, I hear, and if you read the newspaper you'll see often people come up with other things that tomatoes are good for you. Keep an eye out for any signs and symptoms. If you have any concerns, see your GP or ring the helpline. Numbers up for the helpline. It's a confidential helpline staffed by specialist nurses. You can also find it by email, and they will know all the latest facts, all the latest treatments. They can talk to you about it, can tell you and answer a lot of your queries, and if necessary, they will arrange for one of us volunteers to ring you and talk to you about what you're going through, because we've been there. There's a range of publications that are free. The toolkit contains detailed information on diagnosis, treatment and side effects. So there's a lot of information available there. On the way out, there are some small ones that I've brought along that you may find of interest. They're a little pocket one, but they've got phone numbers on and so on, so that might do that. Right, I think that gets us through it fairly quickly.
Way forward of diagnosing and looking at where the cancers are. My issues are around the how you get this information to GPs. GPs are extremely busy. We all know they're dealing with diagnosing thousands of different types of illnesses. How is this information getting to GPs? Because we've heard today already that many people have had different experiences from different GPs in terms of referring them to, if they're referred to an MRI scan. I doubt many people here who've had that experience were referred for an MRI scan. So how does the information get to GPs to enable them to make the correct referral?
So what I've been saying tonight is not standard of care, right? So it's the direction that I think it's going in, and I might be wrong. I think it's unlikely, and if you look at most good centres around the world, they're incorporating imaging prior to biopsy. It just makes sense. To be blind, it just makes no sense to me. So, and I think it's a legitimate response. The current pathway is a very poor pathway. GPs quite legitimately will on your behalf not recommend that pathway to you, and and I think that's perfectly reasonable. And they can express a preference and guide you, and that's the doctor's job, with your informing you at the same time, so that you make a joint decision. I think as we get into this new pathway, and our job is to do the research, so that NICE approve it and PCTs commission it. And that's my job as a kind of researcher. You know, hopefully this pathway, if it does play out as I think it will be available to everybody, and that people in London, because we're doing all the research, will be the first recipients of this in the world. And actually, for UCL Partners, I think, are we in UCL Partners territory?
Yes.
Yeah. So I think UCL Partners will be the first health system to incorporate imaging as part of the pathway in the world. So you are at the epicenter. But nothing in medicine happens overnight, and we can make a lot of errors and harm by introducing things too quickly. And just like breast cancer screening, unless it's done well, it causes havoc. And we have to teach MRI, we have to teach targeted biopsy and stuff like that. But at the moment, I think the message is that you are going to be the first recipients of this pathway in the world when it's ready. We're going to diffuse it out in a responsible and safe manner.
I mean, from a general practice point of view, as a patient, you're entitled to a certain standard of care. So what you should expect from your GP is to be seen for a history to be taken, to be examined, and to be referred for the sent for the appropriate tests and referred as necessary. So there is an existing pathway there, and that's the minimum standard of care that you should expect.
How do you know that your risk of dying of prostate cancer is 3% and not 4% or 2%? And how does that apply to how do you assess other people?
Yeah, so in various countries, and it is 3% in the UK today. My individual risk, I don't know, and we always treat on average. So even when GPs treat people with blood pressure, they treat on average. Not every patient will benefit. Not everybody will have their stroke prevented. But on average, of those 100 patients treated, there will be net benefit, it's hoped. So these are taken from population, and then we make decisions based on averages. And the modern move in medicine, so you know, to apply all these expensive new therapies, how are we going to do it? Well, I think the only strategy that is available is to get away from treating people on average, and to try and derive individual risk, so that you don't treat people unnecessarily, wastefully, and you apply the treatments to the right patients at the right time. And this is kind of individualized medicine, personalized medicine are the kind of buzzwords. But something like MRI would allow you to do that. So at the moment, you know, everybody with a high PSA gets a biopsy. An MRI would actually prevent 2/3 of men having a biopsy, which is a lot, you know. There are 150,000 biopsies done in the UK a year. We could probably get rid of 100,000 just by applying this test. The worst error is diagnosing somebody who isn't going to benefit, because then he exposes himself to treatment, incurs cost, suffers harm. Nobody benefits, you know. Makes the figures look good, you know, because you know, screening works, but of course it doesn't. You're treating people that were never going to die of it. And so I think it's finding tests that individualize the risk. Long answer, I apologise.
And a lot of talk has been centred around statistics and percentages and everything else. Can I just ask the question, are there different types of prostate cancer, and do they progress at different rates?
A fantastic question, and the answer has to be yes. You know, and most of us will have prostate cancer that we describe as indolent. In other words, our immune system lives with them harmoniously, and most men die with prostate cancer. You know, most men have prostate cancer cells in their prostates when they die. If you meet an 80-year-old, he's almost certainly got prostate cancer cells. It doesn't mean that he's going to suffer any harm. And yet sometimes, and we don't know which way it plays out, those cells undergo a change, a genetic mutation, which makes those cells more likely to grow, escape the immune system, invade and spread. Now, we don't know whether the bad cancers come from the good cancers or they're born different. And that's something we just don't know at present. Most cancers in most men grow really slowly. They take 1,000 days to double, you know, and we will outlive most of these cancers by some margin. Some cancers, very occasionally, grow very, very quickly, and they're the ones that are aggressive and invade. And they may occur too quickly for us to detect, actually. The so-called interval cancers, they occur between the screening episodes. So there are many times, and it is the modern challenge, is to identify clinically significant disease.
So of all the different types of cancer that are possible in the prostate, what percentage of them are likely to cause a man to die of prostate cancer rather than die of something else? If you can understand what I'm trying to establish.
If we assume they live a long time, 3% death, if we assume all men are going to get prostate cancer or have it, which is not far off, 6% symptomatic. So, so it will develop disease that affects their quality of life but doesn't affect the quantity of life. And 3% of men will develop, this is overall, or 3% of all men will develop disease that will result in a premature death. So it's the minority, but it's still 1 in 20, 1 in 30 of the cancers. So it's a tough one, because most won't. Yeah, it's a tough call to diagnose a test that identifies those 6%, or it'll never be perfect test, so it'll probably identify 9% or 10% of all the cancers, and then treat those.
So based on that probability, there's not a lot of, it's not cost effective to nip down to the local hospital, pay 125 quid and have an MRI scan.
I don't know about the cost-effective argument. They're very difficult things to calculate because it's the cost of care. So if you prevent one man from having an unnecessary diagnosis, you prevent a lifetime of care, which is very expensive. And the cost of 20 years of incontinence and impotence and things like that you're preventing. So I think of all the tests available, so what would I rather have? An MRI or a biopsy? MRI every time. That's me speaking personally. There would be many other urologists that wouldn't agree with me if they came and debated this tonight. And I'm just giving you a glimpse to the future, which I think is bright, because I think tests are emerging that are going to improve on existing tests. But as we've already said, these tests aren't widely available yet, and they're not ready for prime time. Right? But I think they will be.
Can I just add that £120 is the NHS tariff price. You'd expect to pay a lot more than that if you went for a private MRI.
Yeah. Okay. 1,000.
Yeah, you'd have to pay for that.
I would like to bring to your attention another good quality no nonsense seminar on the 21st of October around breast cancer, breast screening. This is going to take place in Latimer, which is off Church Street, N9. It's in Churchfield School. And please let your neighbors, friends know about this one. It's just equally important to know about breast cancer because, as I was told by Karen today, there is a 3%.
Είμεθα εδώ στο Δημαρχείο του Enfield, όπου λαμβάνει η χώρα το σεμινάριο που οργανώνει ο Σύνδεσμο Λευκαριτών Μεγάλης Βρετανίας σε συνεργασία με το Δημαρχείο του Enfield, το NHS Enfield και το Healthe Enfield. Εδώ έχουν μιλήσει μέχρι τώρα ο Mike Embeton, professor στον καρκίνο του προστάτη στο University College Hospital και ο Dr Abedi. Ήταν μια επιτυχημένη βραδιά όπου ένας σεβαστός αριθμός συμπατριωτών μας και φυσικά ξένων έχουν παρευρεθεί σε αυτήν την ωραία εκδήλωση σεμινάριων, καλής ποιότητας σεμινάριων μπορώ να πω, με πολύ καλών περιεχόμενων που έχουμε μάθει αρκετά πράγματα που δεν ξέραμε μέχρι σήμερα. Έχουμε μαζί μας εδώ μεταξύ των παρευρισκομένων τον Μιχάλη Μπιερέτσι που παρακολούθησε την όλη βραδιά, τη Χρυσάνθη Γιαπάνη και θα πω πολύ ενδιαφέρον να μιλήσουμε πρώτα στον κύριο Μιχάλη Μπιερέτσι.
Ναι, Γιώργο μου.
Πώς σας φάνηκε η ομιλία απόψε του Mike Embeton, του Professor?
Ναι, ήταν πολύ σημαντική και μορφωτική. Φυσικά είχα πολλούς φόβους για αυτό το θέμα, αλλά τώρα...
Έχεις καθησυχάσει.
Έχω καθησυχάσει εντελώς. Ναι. Ήταν πολλά ωραίο και πολύ ωραία η οργάνωση. Μπράβο Γιώργο.
Να σε καλά, ευχαριστώ κύριε Πυρέτση. Χρυσάθη Απάνη, μέλος του Λευκαριτών, γνωστή στην παροικία για το έργο της στην κοινότητα, την παροικία γενικά, και είσαι από την Αγία Κατερίνη, την κοινότητα της Αγίας Κατερίνης.
Yes.
Και πώς σου φάνηκε απόψε η βραδιά?
Εξαιρετικά ενδιαφέρουσα, πλούσιο το θέμα. Ο Professor Embeton ήταν υπέροχος, μας τα εξήγησαν όλα πολύ με λεπτομέρεια.
Με απλά λόγια, τα οποία καταλαβαίνει όλος ο κόσμος.
Ναι. Και είχα πολύ ενδιαφέρον κατά ακρίβεια, διότι ο σύζυγος μου έκαμε radical prostatectomy και το ανάφερε ο Dr Abedi, το ανάφερε εκεί και πάρα πολύ με ενδιαφέρει αυτό.
Συνήθως σε τέτοια σεμινάρια βλέπεις τον κόσμο να κινείται, όλοι κάθισαν με ευλάβεια, μπορώ να πω, με προσοχή και άκουγαν κάθε λέξη που... Μπράβο, διότι ήταν κάτι το άγνωστο. Μας έπειρε κάπου που δεν ξαναείδαμε, πώς εργάζεται το MRI και όλα αυτά.
Ναι, τα εξήγησε υπέροχα. Δεν μπορείτε να φανταστείτε πόσο...
Δεν νομίζω ότι ο σύνδεσμος Χρυσάθη, ο σύνδεσμος Λευκαριτών κάνει μια καλή εργασία στην παροικία μας.
Ο Σύλλογος Λευκαριτών κάνει διάφορα σεμινάρια, τα οποία είναι πολύ ενδιαφέροντα στην παροικία και ωφελούν την παροικία.
Δεν είναι μόνο για τους κατοίκους του Enfield, αλλά για όλα τα δημαρχία μπορούν όλοι να έρθουν, διότι τα διαφημίζουμε στο Hellenic TV, τον ευχαριστούμε που ήταν εδώ απόψε.
Το επόμενο 31 Οκτωβρίου.
Τον καρκίνο του μαστού, στο οποίο όπως ακούσαμε απόψε, η δική μας, η συμπατριώτισσα μας, η Dr Ζωή Βλαμάκη, θα είναι παρόν.
Ναι.
Δυστυχώς δεν είναι μαζί μας απόψε, λόγω του ότι ήταν σε ένα σεμινάριο στην Αμερική, σε ένα conference. Αλλά είμαστε στην ευχάριστη θέση να πούμε ότι η Dr. Ζωή Βλαμάκη θα είναι μαζί μας στις 31 στο Latimer Road, στο Churchfield School. Ευχαριστούμε τον Hellenic που πάντα μας ακολουθεί, καλύπτει τις εκδηλώσεις μας και εύχομαι να συνεχίσει την ιεράν αυτήν δουλειά που κάνει στην παροικία.
Ευχαριστούμε πολύ.
With us, it's an honor to have the leader of the council, Councillor Doug Taylor, to tell us a few things about the importance of these seminars that take place in Enfield.
Well, good evening, George, and can I congratulate you for all the work that you've done in order to ensure that this has occurred tonight.
Doug, may I say that without the Enfield Council's backing, support and guidance, Enfield NHS, the Enfield Council itself, and Healthy Enfield, this wouldn't be possible. We're only here to coordinate, and I would like to thank you as well for all your support.
I think it's very important that the Council takes a leading role in helping people understand issues related to their health. Council now has a major role in public health information, and prostate cancer, as you know, is the second biggest killer of men in the cancer world. So it's important that men understand the symptoms of prostate cancer and what they can do about it.
How is the Council going to continue to provide this kind of support to organizations to promote health issues?
Well, I know there's another seminar at the end of October on breast screening, and that's another important area. But overall, now that the Council has responsibility for public health, we have to look at how we can help people understand the implications of their lifestyles, but also understand what sort of things to look out to improve their health. The Enfield, although it's a relatively prosperous borough, has major difference in life expectancy in different parts of the borough, and we need to help people to understand what's the best course of action they should be taking.
Some kind of development in not only in employment but also the quality of life. You have an academy there now and other sort of local amenities.
Let's take the starkest difference. A woman in the east of the borough, their life expectancy is 11 years less than a woman in the west of the borough. And there is a similar but not quite as dramatic difference for men between the west and the east of the borough.
That happens in Enfield alone.
That's in Enfield. So it happens in other boroughs. You get differences of life expectancy, but that's the Enfield one. What we have to do is to try and narrow that. We have to try and improve the health of the people with the lowest life expectancy. And to me, the sort of work that's gone on here tonight is one way of trying to begin a process to do that. If you catch issues of cancer early, your chances of getting through it are much, much better. But men, we know, don't like to go to the doctors. Men, and there are issues, as we know, about prostate cancer, about people being embarrassed and so on and so forth. We have to get over that. So what the council needs to do is to assist by trying to help people help themselves.
Thank you very much, Doug. And any other message you'd like to pass on through to all the viewers of Hellenic TV?
Well, what we as a council are committed to do is to try and improve the life of our residents, wherever they are in the borough, and we will work continuously to try and make that occur.
Thank you very much, and wish you every success in your efforts to bring a better quality of life to Enfield and to all the people that live in it.
Thank you, George.
Thank you.
Thank you.
Thank you.